Welcome back to the deep dive. Today we're jumping into something really fundamental for all of you in nursing, understanding anti-infective agents, how they work against infections.
Right. We've looked at quite a bit of material to really boil it down for you, focusing on the core principles you'll need.
Yeah, the idea is to make sense of anti-infective therapy, how these drugs function, the big challenge of resistance, and what's really important for patient care.
Exactly. Think of this as clarifying the essentials.
All right, let's start with the basics. Anti-infectives, what's the main idea here?
Well, at their core, these are drugs designed to go after foreign organisms, invaders, basically, that have set up shop in the body and are causing an infection. We're talking bacteria, viruses, fungi, parasites.
It's kind of amazing when you think about how long we've been battling these things. How did we even get to the point of having specific drugs?
Oh, it's a long story. People have tried things for centuries, using plants, even mold sometimes, ancient remedies. But the real scientific approach, developing synthetic drugs and actually understanding how they target these microbes, that really kicked off more in the 20th century.
And a huge part of that understanding is selective toxicity, right? Why is that concept so critical?
Yes. Selective toxicity is, well, it's the golden rule, really. It's the drug's ability to harm the invading organism without causing significant damage to the patient's own cells.
So hit the bad guys, spare the good guys.
Pretty much. Ideally, anyway. The goal is high selectivity, like a drug that messes up bacteria but leaves human cells alone. But it's important to remember it's never perfectly selective. That's why we see side effects, which we'll definitely get into.
Okay. And it's not just antibiotics, even though we hear that term a lot.
No, definitely not. Antibiotics are specifically for bacteria. But the anti-infective umbrella is much wider. You've got antivirals for viruses, antifungals for fungi, antiprotozoals for things like malaria, anthelmintics for worms.
That's quite the arsenal.
It is. And just briefly, you can even mention anti-neoplastics cancer drugs. They aren't technically anti-infectives, but they work on a similar principle of targeting rapidly dividing cells. Just in that case, it's abnormal human cells.
Gotcha. Okay, so we know what they target. How do they actually do it? What are the main ways these drugs work inside the body?
The main strategy, across the board, is to interfere with some function that's essential for that invading organism to survive or reproduce. You want to stop it from multiplying and ultimately cause it to die, while, again, trying to minimize harm to the host.
Can you give us some examples of these interference tactics?
Sure. A really big one is messing with the construction of the pathogen's cell wall. Think of it like sabotaging the building materials for their protective outer layer.
Okay.
This works great against bacteria because their cell walls are structurally quite different from our cells. Penicillins are a classic example of drugs that do this.
Right. I remember learning about that difference. What else?
Another key way is to prevent the pathogen from using substances it absolutely needs to grow and develop, sort of like cutting off its food supply or blocking a key metabolic step. Sulfonamides, for instance, block a pathway needed for bacteria to make essential components for division.
So hitting them where it hurts their basic survival needs.
Exactly. Then you have drugs that target protein synthesis. Proteins do all the work in a cell, so if you disrupt their production, the cell can't function or replicate properly. Aminoglycosides and macrolides are examples that interfere with the bacterial ribosome, which is their protein-making machinery.
Makes sense. Any other major mechanisms?
Yeah, a few others worth mentioning are interference with DNA synthesis, stopping the pathogen from copying its genetic blueprint. Fluoroquinolones do that. And some drugs work by changing the permeability of the pathogen cell membrane, essentially making it leaky so vital stuff leaks out. You see that with some antibiotics, antifungals, and antiprotozoals.
That paints a really clear picture of the different angles of attack. Now, I often hear broad spectrum and narrow spectrum. What's the difference and why does it matter?
Good question. The spectrum of activity tells you the range of microorganisms a drug is effective against. Broad spectrum drugs work against a wide variety, maybe various types of gram-positive and gram-negative bacteria.
Like a shotgun approach.
Kind of, yeah. Whereas narrow spectrum drugs are much more targeted, effective against only a very specific group or type of bacteria.
So when would you use which?
Ideally, if you know exactly what bug is causing the trouble, often from lab tests, a narrow-spectrum drug is preferred.
Why is that?
Because it does the job while causing less disruption to the body's normal beneficial bacteria, the normal flora. And using narrow-spectrum drugs when possible helps reduce the pressure that drives antibiotic resistance.
Okay. Less collateral damage.
Precisely. But if the infection is severe and you don't know the specific cause yet, Or maybe you suspect multiple types of bacteria are involved. A doctor might start with a broad-spectrum drug to cover the likely bases while waiting for culture results.
That makes sense. What about drugs that kill versus drugs that just stop growth? Bactericidal versus bacteriostatic.
Right. Bactericidal drugs directly kill the microorganisms. They often achieve this by causing irreversible damage, like poking holes in the cell wall or membrane. Bacteriostatic drugs, on the other hand, don't kill outright. They inhibit growth and reproduction. They basically stop the bacteria from multiplying.
So they hold the infection in check.
Exactly. They slow things down enough that the patient's own immune system can then step in and clear the infection. It's worth noting, though, that the line can blur sometimes. A drug might be static at low doses, but cidal at higher ones, or its effect can depend on the specific bug.
Which brings up the immune system. So the drug isn't usually doing the entire job on its own?
Not usually, no. Especially with bacteriostatic drugs. But even with bactericidal ones, the goal is often to reduce the number of pathogens, the bacterial load, down to a manageable level. Then, the patient's own immune response, their white blood cells and antibodies and so on, can take over and eliminate what's left. A healthy immune system is a really crucial partner in fighting infection.
What happens if someone is immunocompromised, say, due to illness or medication?
That makes things much tougher. If someone's immune system isn't firing on all cylinders, maybe due to malnutrition, age, AIDS, or immunosuppressant drugs after a transplant, their body might struggle to clear the infection even with the help of anti-infectives.
So what does that mean for treatment?
It often means treatment needs to be more aggressive, maybe using bactericidal drugs, possibly higher doses, or longer treatment courses. And the risk of the infection coming back is higher. In these folks, preventing infections in the first place through hygiene, vaccines, good nutrition becomes incredibly important, working alongside any necessary drug therapy.
Okay. This naturally leads us to probably the biggest concern we hear about: resistance. Antibiotic resistance. What exactly is resistance?
Resistance is when microorganisms, like bacteria, figure out how to survive exposure to a drug that used to kill them or stop their growth. The drug basically stops working against that particular strain.
It adapts.
It adapts, exactly. There's natural resistance where a bug just doesn't have the target the drug goes after. But the bigger problem is acquired resistance, where bacteria that were once susceptible develop ways to withstand the drug.
And this is a huge issue, right?
It's a massive global public health crisis. We're seeing strains of bacteria emerge that are resistant to multiple, sometimes nearly all, available antibiotics. This means infections that used to be easily treatable can become life-threatening again. It leads to longer illnesses, more hospital stays, higher treatment costs, and tragically higher death rates.
How do they actually do it? How do bacteria become resistant?
They have quite a few tricks up their sleeves, unfortunately. One very common way is they start producing enzymes that actually break down the antibiotic molecule. The classic example is penicillinase, or beta-lactamase, which chews up penicillin and related drugs.
So they fight back chemically.
They do. Another way is changing their own structure, maybe making their outer membrane less permeable so the drug can't get inside, or developing pumps that actively spit the drug back out if it does get in.
Wow.
They can also alter the target site the drug usually bonds to, like changing the shape of a piece of their ribosome so an antibiotic, like a macrolide, can't latch on anymore. Or sometimes they even develop whole new metabolic pathways to get around the one the drug is blocking.
It sounds like an arms race. How does this resistance actually spread through a bacterial population? Is it just random mutation?
Mutation plays a role, yes. A random genetic change might happen to make one bacterium slightly less affected by a drug, but a major driver is selection pressure. When you use an antibiotic, it kills off the susceptible bacteria,
leaving the slightly tougher ones behind.
Exactly. Those few, naturally less susceptible or newly mutated resistant bacteria survive, and now they have no competition. They multiply, and soon the whole population is resistant. So the antibiotic use itself selects for resistance.
Okay, so the drug doesn't cause the mutation, but it favors the survival of resistant bugs.
Correct. And bacteria are also really good at sharing genetic information. They can pass resistance genes directly to each other, even between different species, through processes like conjugation. This allows resistance to spread incredibly quickly.
This is genuinely scary stuff. What can we as healthcare providers actually do to try and slow this down? It feels like a huge challenge.
It is, but we absolutely have a role. The most critical thing is antimicrobial stewardship, using these precious drugs wisely. First, only use anti-infectives when they're truly indicated. primarily for confirmed or strongly suspected bacterial infections. Don't use antibiotics for viruses like the common cold or flu. They won't help and just contribute to resistance.
That seems obvious, but it still happens a lot, doesn't it?
Yeah, it does, often due to patient pressure or diagnostic uncertainty. Second, when an antibiotic is needed, try to use the most narrow-spectrum drug that will be effective against the identified pathogen. Get those cultures done. Identify the bug and see what it's sensitive to.
Right, target the therapy.
Precisely. And third, ensure proper dosing and duration. You need a high enough dose for long enough to wipe out the infection completely, including any slightly less susceptible bacteria hanging around.
Which is why finishing the full course is so important, even if you feel better.
Absolutely vital. Stopping early is a recipe for selecting resistant survivors. Patients must understand this. No saving pills for later. No sharing antibiotics. These are dangerous practices.
So education is key.
Huge. And for us, getting cultures before starting antibiotics whenever feasible is best practice. Even if you have to start broad-spectrum empirically for a very sick patient, you aim to narrow the therapy down once you have the culture and sensitivity results.
We've mostly focused on treating active infections, but sometimes anti-infectives are used to prevent infection, right? Prophylaxis.
Yes, that's another important use. Prophylaxis is giving an anti-infective to prevent an infection from starting. There are specific, well-defined situations where this is beneficial.
Like what?
For example, patients at high risk for endocarditis, an infection of the heart lining, often get antibiotics before dental procedures or certain surgeries. People traveling to areas with malaria take preventative antimalarial drugs. And surgeons often give antibiotics just before specific types of operations to reduce the risk of surgical site infections.
Okay, so targeted prevention in high-risk scenarios. Let's shift back to treatment, specifically systemic infections, the ones affecting the whole body. Anti-infectives must have been revolutionary here.
Oh, completely. Diseases like bacterial meningitis, sepsis, severe pneumonia, these are often fatal before effective antibiotics. Anti-infectives have transformed our ability to manage these critical illnesses.
What's the key to success when treating these serious systemic infections?
Identification, identification, identification. You absolutely need to know which pathogen you're dealing with. This usually involves collecting samples, blood, urine, sputum, spinal fluid, whatever is appropriate, and sending them to the lab for culture.
Growing the bug to see what it is.
Exactly. They grow it on agar plates, use staining techniques, look under the microscope. For parasites, maybe examining stool samples once they isolate the organism.
Then you test it against different drugs.
Right. That's sensitivity testing. They expose the cultured bug to various anti-infectives to see which ones inhibit its growth or kill it. This is non-negotiable, especially with rising resistance rates. The culture and sensitivity, CNS results, are what guide the clinician to choose the right drug for that specific infection in that patient.
Makes sense. What about using multiple anti-infectives together? Combination therapy, when does that come into play?
Combination therapy is used strategically. Sometimes two drugs together have a greater effect than either one alone. That's synergy. You might also need it if you're dealing with an infection caused by several different types of pathogens. A really important use is to help prevent or overcome resistance, especially for tough infections like tuberculosis, HIV, or sometimes severe hospital-acquired bacterial infections. Hitting the bug with multiple mechanisms makes it harder for it to develop resistance to everything at once.
Are there downsides to using multiple drugs?
There can be. It usually increases the cost, and importantly, it increases the risk of adverse effects and drug interactions because the patient is exposed to more medications. So it's reserved for situations where the benefits clearly outweigh those risks.
All right, we've covered how they work, how we choose them. Let's talk about the potential problems. Adverse reactions. These drugs aren't perfectly harmless, are they?
No, definitely not. Because they're targeting living cells, even with selective toxicity, there's always potential for collateral damage to the patient's own cells. We see common patterns of adverse effects involving certain organ systems.
Like the kidneys, you mentioned that earlier.
Yes, kidney damage, or nephrotoxicity, is a significant concern with certain anti-infectives, especially those eliminated by the kidneys, like the aminoglycosides. Gentamicin is a common example. They can directly harm kidney tubule cells.
So monitoring is key.
Absolutely. Monitoring kidney function tests, like creatinine levels, and ensuring the patient stays well hydrated are crucial when using potentially nephrotoxic drugs.
What about the gut? GI issues seem common with antibiotics.
Very common. Nausea, vomiting, diarrhea, abdominal cramps, Many patients experience these. It can be direct irritation of the GI lining, or sometimes it's caused by the drug disrupting the normal gut bacteria, or even toxins released by dying bacteria.
And can they affect the liver too?
Yes, some anti-infectives can cause liver toxicity or hepatotoxicity. This might range from mild temporary elevations in liver enzymes to rarely severe hepatitis or liver failure. Drugs like some cephalosporins have this potential. Again, monitoring liver function is important for patients on long-term therapy or those taking known hepatotoxic agents.
What about the nervous system? Neurotoxicity sounds worrying.
It can be. Some drugs can damage nerves or interfere with nerve function, especially if drug levels get too high. We mentioned aminoglycosides potentially affecting the eighth cranial nerve, causing hearing loss or balance problems like dizziness and vertigo. Chloroquine, an antimalarial, can affect the retina. Others might cause things like headache, drowsiness, confusion, or even seizures in susceptible individuals.
Then allergies, hypersensitivity reactions. We have to be vigilant about those.
Always. Allergic reactions can happen with almost any drug, but they're notably common with penicillins and related drugs like cephalosporins. The immune system mistakenly attacks the drug.
Ranging from mild to severe.
Exactly. It could be a simple rash, or it could be life-threatening anaphylaxis with difficulty breathing and a drop in blood pressure. That's why getting a detailed allergy history is non-negotiable. And we need to be aware of cross-sensitivity. Someone allergic to penicillin might also react to a cephalosporin. It's also important to differentiate a true allergy from a predictable side effect, like nausea.
Okay. And one more, you mentioned superinfections. Can you explain those again?
Sure. Superinfections happen when the antibiotic you're using wipes out not just the bad bacteria, but also some of the good protective bacteria of the normal flora, usually in the gut, mouth, or vagina.
Creating opportunity.
Precisely. This allows opportunistic organisms that weren't susceptible to the original antibiotic, often fungi like Candida, or resistant bacteria like Clostridium, difficile to overgrow and cause a new infection on top of the first one.
Like yeast infections or C. diff diarrhea.
Those are the classic examples.
Yeah.
So we need to watch patients for signs like white patches in the mouth, thrush, vaginal itching or discharge, or severe diarrhea, which could signal a superinfection developing during or after antibiotic treatment.
It's clear there's a lot to monitor. Does age change how we approach these drugs? Are there specific concerns for kids or older adults?
Yes, age is definitely a factor. With children, their bodies are still developing, so they might metabolize drugs differently or be more sensitive to certain side effects, especially GI and nervous system effects. There's also that ongoing discussion about antibiotic overuse for things like ear infections in kids and how that fuels resistance. Keeping them hydrated and nourished during treatment is also key.
And for adults?
Well, adults are the main population dealing with established allergies and encountering resistant organisms. A huge consideration in adults is pregnancy and breastfeeding. Many anti-infectives can cross the placenta or get into breast milk, posing potential risks to the fetus or infant. It requires very careful risk-benefit assessment.
Makes sense. What about older adults? They often have other health issues.
Exactly. Older adults are more likely to have decreased kidney or liver function just due to aging, which can slow down drug elimination and increase the risk of toxicity. They often take multiple medications, raising the chance of drug interactions. Their infections might present differently, less typically, making diagnosis harder, and they can be particularly vulnerable to severe GI effects like C. diff or neurotoxicity. Monitoring organ function, hydration, and nutrition is extra important in this group.
Wow, this has been incredibly thorough. If we had to boil it down, what are the absolute must-know principles for nurses listening today?
Okay, key takeaways. Grasp selective toxicity, hitting the bug, sparing the host. Know the difference between broad and narrow spectrum and why it matters. Understand the main ways these drugs work, cell wall, protein synthesis, etc. Recognize that resistance is a huge growing threat, and stewardship, using drugs wisely, proper dosing, finishing the course is paramount. Appreciate the need for culture and sensitivity testing. Be vigilant for adverse effects, kidney, GI, neuro, allergic reactions, superinfections. And finally, remember to tailor your approach based on patient age and specific circumstances like pregnancy or compromised immunity.
That's a great summary. It really highlights how foundational this knowledge is, especially with the ongoing fight against resistance. It emphasizes the crucial role nurses play in safe and effective anti-infective use. Maybe for a future deep dive, we could explore specific drug classes in more detail.
That would be a great next step.
Well, thank you for joining us for this essential discussion today.